October is Breast Cancer Awareness Month. Dr. Grace Makari-Judson chairs the Baystate Health Breast Network and is co-director of the Rays of Hope Center for Breast Cancer Research. She came in to talk with us about the great strides being made in battling breast cancer.
It's really impressive how dramatic the improvement in survival is for all individuals with breast cancer over the last 30 years. And treatments have improved all the way around. Surgery is better. We're doing more with less. Radiation has refined techniques. And with medical oncology, my specialty in particular, we are much better in being able to decide what treatment is best for a particular individual. So it's not one size fits all. For some individuals, it may be hormone treatment. For some people, it may be chemotherapy. For some people, it may be a monoclonal antibody. But we're really targeting the treatment and individualizing it, and that has made a huge difference.
Right here in Springfield at the Rays of Hope Center for Breast Cancer Research, you are involved in, you are in many cases coordinating amazing amounts of work, participating in clinical studies. You just got a big $3.5 million grant, and this is a big deal in the medical science field, from the National Institute for Environmental Health Studies, basically looking at regular things that are around our house, household chemicals, cosmetics that people, women may use, and does that impact breast cancer?
Well, part of this grant has to do with the fact that pregnancy can be protective for breast cancer. So why is it in some women there may be exposures that may differ, may impact upon this protective benefit? We are not necessarily implicating any of these substances that are being studied. However, what we're really trying to achieve is to be able to ease somebody's mind about certain obvious day-to-day exposures. But if there is a cause for concern, to be able to delve into that deeper and really be able to substantiate it. But probably the best thing about this grant is that it's really substantiated the infrastructure that we set up for the Rays of Hope Center for Breast Cancer Research, where small grants, and when I say small, I mean 25,000 to 50,000, can give us enough initial data to make us competitive to then apply for these big NIH grants. And the other piece that made us competitive is the fact that we have an advocate, a breast cancer survivor, as part of the research team to be able to say, yes, this research is relevant, and also that we're able to say that we have an engaged community. Because look at our community, look at what Rays of Hope has done for our community in terms of interest and awareness and support for this kind of work.
I want to ask you about another clinical trial I heard about that you're involved in. I find this so interesting, and I don't want to get lost in the weeds of the science of it because it's easy to do, but am I right that it involves looking at a new drug specifically for women who carry BRCA, the BRCA gene mutation?
Yes. We do have a trial currently for women that have higher risk breast cancer, that have a BRCA1 or 2 mutation, where they may have the opportunity to receive one of these targeted agents. And so, yes, this is one of the areas that is really changing breast cancer, and that's that we're looking at the disease not as one size fits all, but really in terms of some very specific aspects of the biology of the cancer so that we can pick the very best treatments.
You're also, I believe, behind some research on the relationship between obesity and diabetes, big problems in our society, and breast cancer. That's a fascinating area to look at, I would think.
It is. We understand that obesity after menopause is a risk factor for the development of breast cancer, but yet for reasons we don't fully understand, obesity in young women is not a risk factor and might be protective. We know that for women that have had a diagnosis of breast cancer, women that are overweight or obese may have a worse prognosis than others. while there is no breast cancer prevention diet, we do know that women that exercise regularly can reduce their risk of breast cancer recurrence in those breast cancer survivors that have had a diagnosis. So it's a fascinating area, and it's one where I think women are very interested in seeing this kind of research, because after they've gone through their treatment, they then say, well, what can I do now? You know, I've had my surgery, I've had my radiation, I've had my chemotherapy, I'm taking my hormone medicine. So, you know, being able to be proactive about healthy lifestyles, I think, is really important.
I was mentioning to you before we started the taping that it's rare, and we say breast cancer, we tend to think of women, but I mentioned a family friend, gentleman in his 40s, recently underwent a double mastectomy. It's rare, but it does happen to men. We need to think about it.
1 in 100 breast cancer cases will occur in a man. In men that develop breast cancer, we get more suspicious about a hereditary susceptibility. So, for example, a BRCA1 or BRCA2 mutation. So we will always test men for genetic susceptibility. Essentially, though, the treatment in men is similar to the treatment in women.
Mammography is one of the standard tests that you recommend women have regularly to check on the breast and the breast tissue. The American Cancer Society very recently changed its recommendations for breast cancer screening. They're saying if a woman doesn't have a specific risk factor, normal or regular risk as they put it, they're strongly recommending beginning regular annual mammograms at age 45 rather than 40, which I think has been sort of the rule for most folks recently. Correct me if I'm getting any of this wrong, because I found it a little complicated when I read their report.
So screening mammography recommendations are very confusing because different societies have different recommendations. So let's start out with just some basics, and that is screening mammography doesn't prevent breast cancer. So for example, colonoscopy, screening colonoscopy does prevent colon cancer, and we have seen decreases in the likelihood of dying from colon cancer when people have a colonoscopy and they have a polyp removed. So with mammography or with any kind of breast imaging, whether it's MRI or any type of breast imaging, none of those screening modalities actually prevent breast cancer. The hope is with those modalities that they pick up breast cancer earlier so that it's more treatable. But, you know, unfortunately, Jim, sometimes we pick up a small cancer and it's an aggressive cancer. So did it really make a difference that it was small or that it was large? I mean, really, that's part of the debate. So the debate about screening mammography includes the fact that women that have mammograms that are of average risk may end up having more biopsies and more tests as a result of the mammogram. And so that's really the basis for this. The recommendations are different in different parts of the world. In some countries, they've completely stopped screening mammography, and they've said it's really a discussion between a woman and her physician if she wants to have it at all. I think that the most important thing for your listeners to understand, for women to understand, is number one, first and foremost, have a discussion with your clinician about what your risk is, if you're average risk or if you're high risk. You're high risk if you have a certain family history, if you've had a biopsy that shows certain types of benign breast disease, if you've had radiation for Hodgkin's disease, for example, as a young woman. So there are people that the screening recommendations do not apply to. But for the average risk person, we have recommendations from the U.S. Preventative Services Task Force that says start at age 50. The American Cancer Society had been saying start at age 40, and now I think this is their compromise of saying, oh, well, we're 10 years off from the other guy, so now we'll say 45. Again, our perspective is really that women should have an individual discussion. They should be aware of the fact that if they're average risk, they may have more additional tests and unnecessary biopsies as a result of the imaging. But, you know, for women that are at higher risk, again, it's a very different discussion.
Well, Dr. Grace Makari-Judson, thank you so much for all you're doing. Thanks for coming in and spending some time with us.
Appreciate it. Pleasure to be here as always.